So we'll quickly try and cover a very, very complicated topic of nystagmus. And whenever you come across a child presenting with ocular oscillations, my first question would be, is it nystagmus? Because you need to differentiate it from many other disorders like periodic horizontal deviation, saccades, even um, eye bobbing or nystagmoid movements, what we call. So our first understanding of nystagmus is that it's a rhythmic, involuntary to and fro movement of the eyes. And all components of this should be true before you call it a nystagmus. Involuntary, rhythmic, and complete to and fro. So nystagmus, once you diagnose or you say it's nystagmus, your next question comes, is it physiological or it's pathological? Physiological nystagmus would be endpoint nystagmus, which is not uncommon to see, vestibular, optokinetic, and sometimes very smart children present with voluntary nystagmus. So the endpoint or most physiological nystagmus usually will present in extremes of gaze. The primary trajectory is horizontal. They are not sustained for too long. They kind of dampen out after a few beats. They're low amplitude and symmetric, as is that they have the same amplitude and waveform in both the eyes. And of course, there is no other pathological neuro-ophthalmological sign is present. So pathological nystagmus is, of course, anything that is not physiological. We tend to understand in the way that it is possibly due to vision loss or a motor nystagmus where an integrator function is abnormal, or else a vestibular nystagmus, although CMAS actually has not defined them as sensory and motor, but we continue to use it because it helps us to manage these patients. The moment you say it's pathological, my question comes whether it's acquired or congenital. And it's very, very important to differentiate acquired from congenital nystagmus because you need to get a detailed evaluation for acquired. And key features would be a recent onset or a later age of presentation. Patient will complain of oscillopsia, that the images shimmer or move. Some patients of infantile or congenital nystagmus actually complain of shimmering of the image, but that is not very uncomfortable for them, and they just notice the image occasionally, but it's not something that stops them from functioning. And of course, associated neurological symptoms in acquired. So the moment you have an acquired nystagmus, discuss with neurologist, manage with neurologist. Our discussions essentially are congenital or infantile nystagmus. Like I said, we kind of say there are sensory or motor. So sensory nystagmus is an association with poor vision primarily, and because of poor vision, they do not have a good fixation fusion mechanism that results in the nystagmus like you see in children with bilateral congenital cataract. And motor nystagmus essentially in which they have a good visual acuity. However, because of the nystagmus, it may not be absolutely normal, and you see certain very classical features like head postures in them. So pathological nystagmus in infancy is essentially three types, although there are many, but from an ophthalmologist point of view, we're looking at three very important ones. Infantile nystagmus syndrome, which was earlier called the congenital nystagmus, fusion maldevelopment syndrome, which was also called the latent or the latent manifest nystagmus, and Spasmus Nutans syndrome. So infantile nystagmus syndrome is a binocular uniplanar nystagmus, which is abolished in sleep, dampened by convergence, and a fact that we tend to use for management. It increases on a fixation effort. So a patient tries to be anxiously look better or clearer, actually increases the nystagmus. And an important waveform is an ascending slow phase, which we'll talk about later. Latent manifest, on the other hand, is congenital or infantile, has a jerk and a fast phase towards the fixing eye. So that is a key thing in them. When you cover, you can see the fixing eye, the direction of beat is towards the fixing eye. And that is very, very important to differentiate them from infantile nystagmus syndrome. The key importance of identifying a fusion maldevelopment is that there is no need for imaging in these, and it's because of a fusional maldevelopment that is responsible for the nystagmus. Spasmus Nutans we see in very small children presenting by 6 to 8 months, and they have a head nodding, a head posture, and a nystagmus that is not symmetrical in both the eyes. So the velocity or the amplitude may be different in both the eyes, and it's very important to neuroimage these children because it can be associated with chiasmal gliomas. Usually they are benign and would tend to settle off, but some may be associated with a chiasmal glioma, so you need to investigate these patients. Who do you neuroimage? All acquired strabismus, periodic alternating nystagmus, seesaw nystagmus, Spasmus Nutans, and any nystagmus patient with subnormal vision. So who's having subnormal vision, disc pallor, unless you're able to identify a retinal cause, you need to rule out a neurological cause. You need to measure a head posture and measure the head posture with a visually demanding task. Like this girl does not come with a head posture, but as the demanding task increases, she reads down the Snellen's chart, you can see that the child's head posture starts manifesting, and it's actually a very severe head posture which needed correction. You can measure head postures and nystagmus by videonystagmography or electronystagmography. So these are waveforms you can actually measure. You can see this is primary gaze, and you can see the waveforms decrease in left gaze. So patient looking left, the nystagmus is minimum, and there is no change with either eye occlusion, so there is no latent component to it. And again, this is the waveform with the face turn the child likes to. So we can actually measure now and see what is the angle at which the waveform is minimum. Management is to stabilize, to improve visual acuity, decrease the nystagmus, and if there is a head posture, move that to the primary position. Non-surgical interventions are aimed at improving vision, and optical glasses are the single most important intervention you can do. So age-appropriate cycloplegic refraction give the best corrected visual acuity that itself dampens the nystagmus tremendously, and if required, low vision assistance in these patients. If one eye is amblyopic, give amblyopia therapy. Even occlusion is not absolutely contraindicated, because initially, while even in the latent component may start manifesting, but as the vision improves, the latent component dampens, and you can actually improve the vision in the amblyopic eye also. There are options of medical management as we would see, but as we discussed, optical correction is the single most powerful therapeutic intervention you can do. Over minus lenses here in infantile nystagmus is also possible. Like we talked about, their accommodation actually decreasing the nystagmus. Amblyopia therapy extremely essential. You can dampen the latent component or dampen the manifest component and make it latent. Prisms can be used, base out prisms to stimulate convergence, or preoperatively measure the head posture so that you can check the amount of intervention you need to do. There are alternative therapies like auditory biofeedback and acupuncture. This was a thesis we had done at our center, but unfortunately, this is not long lasting. Similarly, botulinum toxin is possible for acquired nystagmus, but not beneficial for infantile nystagmus syndrome. Medical management has been overall disappointing. We've seen brinzolamide have some effect in infantile nystagmus syndrome in patients who do not have a face turn, but other than surgery for face turn, there is nothing as impactful as surgery. So our treatment options include inducing adduction or convergence, shifting the null position to primary position, and to reduce the amplitude of nystagmus. So face turn surgeries, a lot of surgeries have been described. We prefer the augmented Anderson's, in which we operate on the yoke muscles and do a supramaximal recession of the yoke. So so you do the medial rectus in the 9 millimeters in the eye in the direction of face turn, and 12 millimeter lateral rectus in the contralateral eye. In this way, we shift the face turn or the null point from that gaze to the primary position. And advantages are that you're only doing recessions, you can reverse the recessions, and just in case you've operated on a pan, you can convert it to an all-four recti recession so that you can correct it. This was the kind of face turn we operated. So do the lateral rectus here and the medial rectus here to get a head posture correction. You can even see on the electronystagmography how this improves. So this was primary gaze, and this is the after surgery correction of null position. Dampening of the nystagmus can be done by supramaximal recessions or the Hertel-Delosso procedure. Supramaximal, you do 12 mm recession of both lateral recti and 9 mm recessions of both medial recti, and this places them retroequatorially. And although this has a risk of consecutive exo, but is definitely useful, at least in the initial period. And the alternative is the Hertel-Delosso procedure, where they just disinsert, do a tenotomy, and then reattach the muscle. And this has been found to be fairly effective, but again, both of them tend to come back over time. So I'll just stop share, and maybe we can discuss on the issues that we have managed.